Our next speaker is Asadur Tchekmedyian from the Association Española in Uruguay, and he will be speaking to us about COVID-19, endoscopy services, PPE, and pre-procedure testing. Asadur?
Thank you. Can you hear me? Okay, perfect. Good morning to everyone. Thank you very much, Linda, and now Evelyn, for being part of this colorectal cancer screening committee and to allow us to be here. Thank you also the chairmans. We are now going to speak about endoscopy service, PPE, and pre-procedure testing. Can I move forward or you change slide? Okay, so you can go on with these pictures. It's just to show that there are several pictures here. You can move on, please. Okay, so everywhere in the world, as you know, has been affected by the pandemic, and we react in very, very different ways. And this reaction in the social environment applies also to our healthcare system and the way that we react in our units. And everything has happened so fast. Since the end of the year, last year to now, we has been seeing that everywhere in the world is a red map, is a red flag, and also we are, as you know, in the middle of a pandemic. And as you know, from the early beginning, all recommendations everywhere, all the societies said the same, and they said that all but emergency and absolutely essential endoscopy must stop. And the same with planes, the same with sports, the same with big shows, everything stopped around the world, and we are facing that stop. And as we see in the last slides from the other speakers, that affects not only colorectal cancer screening, if not every activity in the endoscopy units. This is the volume of my procedures, of my unit with our procedures, and you can see the last 2 years, we were more or less the same until March this year and April, that we dropped most of the procedure almost to zero. And this has a tremendous impact. A drastic reduction in screening procedures, a delay in the diagnosis of cancer, a mortality increase due to cancer, and an economic and, what is worse, a psychological impact, not only in us, but in the patients and in all the society. And we react from the societies, from CIED, the Inter-American Society for Digestive Endoscopy, and all the society members, as you can see here in this part of the slide. We react and respond during the health emergency and the pandemic, also taking into account that we face different epidemiological contexts. It's not the same in Argentina, it's not the same in Brazil or the US or Mexico, and it's not the same in my country, in Uruguay. So taking into account all the different realities, we try to write down these recommendations that they are available since March and with updates during the upcoming months. And also, this is very important. I want to show you this survey by the team of Dr. Mura from the organization. And they show, what is this survey from 55 countries show, that we face an 83% reduction in total endoscopy volume during the pandemic. And this is huge. This is huge. These numbers, these figures are of tremendous impact. So I want to make this poll from all of you. I don't know if you can answer from your computers or phones, but I want to see the volume in your unit nowadays compared with pre-COVID COVID era. Are you around a quarter, 50%, 75, or you are full capacity? I think we have 15 seconds to answer this. Okay, so can we see results here or? Okay, so most are around 75%, in my country and in my area, in my region, we are around 50%. So that is, the point is that we are far away from the full capacity as we can, as we saw in the past with the past speakers. Sorry, I have experienced some delay with my computer, but we move on. So this comes from the recommendation of our society, the recommendations for the endoscopy unit. First, we have to take into account that all digestive endoscopies, and I mean all ultrasound endoscopy, ERCP, upper GI, colonoscopy, are considered aerosol generating procedures. That means that we, as doctors and the patients, are at risk during the procedure. And this also, the second line comes from our recommendation, and it says that the recommendation to defer all elective procedures should be handled in the context of the clinical indication and should be weighed against the local need for diagnostic and therapeutic endoscopy. And for that, the discussion with referring physicians, local and regional authorities is encouraged. We think that is very, very much important to have inside your hospitals these kind of conversations in order to achieve the best for our patients. And the big question is who to let in first. We already see some ideas, but the point is that therapeutic endoscopy for sure and diagnostic endoscopy for alarm symptoms are of high priority, the same as FIT positive, especially after 3 months of the test. That are part of the big procedures that we need to move on. The re-evaluation of the indication is very important. This is in some algorithms of some societies, but we consider of extremely importance. Before the pandemic, we were doing a lot of procedures with no clear indication. We cannot permit this nowadays. Also, stratify the risk of the patients due to their background and act in accordance. And also, the allocation of healthcare resources during the restart should be governed by logic. This is very important, not patient proximity or cancer phobia. We experience every day that some colleagues, friends, family call us, because they are facing delay in their procedures. But we cannot allow that, and we need to focus in the first 2 lines. Just one slide about colorectal cancer screening. We already talked too much, but I want to mention that adult primary care and gastroenterology visits have declined around 50%. So this makes very, very difficult to achieve colorectal cancer screening because we are not seeing patients as we see before. And we cannot and should not abandon disease prevention despite of the pandemic. Some words about personal protective equipment. Personal protective equipment is just part of a more wider situation that is prevention. And prevention involves regular hand washing, keeping our immune system healthy. That means have a high quality sleep, doing performance exercise, as we saw before in the presentations, a good nutrition, and also, the personal protective equipment, gloves, mask, face shield, and gowns. And I want to say something about the mask because we have a lot of difficulty to see what different masks are. So first of all, I want to make this poll and ask you which kind of mask are you using during your daily practice. You can vote. Okay. That's great. So this is very important. Let's move on. Because not all masks are the same. And from this slide, you can see here that in one side, we have FDA clear surgical mask. This mask here is different than this mask here, NIOSH approved N95. This one helps us to be protected from the outside, from the patient, and this protect the patient. In the middle, we have surgical N95 respirators. This one protects both from inhale and expel by water. This is different. The codification is different in Europe, in the US, and in other regions, but we all know nowadays what surgical N95 means, and I want to remember these different situations of different type of mask. And something to have in mind and to remember is that health personnel and patient protection measures will never be the same, and this will probably be a good thing and a major improvement in endoscopy practice. But before of the pandemic, we were making procedures without any much more PPE. Just to finalize about the pre-procedure testing, we have different type of tests for COVID, and we have the PCR that detects genetic material. We have antibiotic testing and antigen test. Each of them has advantage and disadvantage, and it relies on different type of sample. For pre-procedure, we, as we heard before, perform the PCR looking for genetic material. And how we perform this? Well, we do the PCR, at least in our unit, we do the PCR 48 to 72 hours before the procedure, and then we see if the clinical situation of the patient permits us to wait for the result, or if not permits. If it not permits, we are facing an emergent procedure, so we need to stratify the risk of the patient and proceed in accordance. If we have time, then we look for the result. If it is negative, we act with appropriate PPE, and if it is positive, and this is very important, and if possible, we need to postpone or even cancel that patient. And if the procedure is mandatory, obviously, we are going to use full precautions. Just to finalize, I want to show you this slide from the movie Demolition Man from Sylvester Stallone in the 1990s. In that movie, they predict a society of no touching. And these were the way that they salute each other. And we are doing that nowadays. And in a review of this movie by this journalist in some weeks ago, he says, as we struggle through quarantine and begin to plan for a post-COVID war, it is important for us not to make decisions based on fear-induced irrationality. Everything is a trade, and there is always a balance between freedom and security, intimacy and hygiene, personal benefit and the common good. Just as in the world of Demolition Man, we need to be careful not to sterilize ourselves so thoroughly that the life we are preserving has lost too much of what makes life worth living. With that, I want to say goodbye and Godspeed to everyone. Just 1 second before I leave, I cannot say goodbye to every one of you without asking for praying for peace in the world, and especially in the place where I came from. Thank you very much.
Asadur, thank you so much for that lovely talk. I'm afraid that we are running behind on time, so we are not going to take questions, and we'll move to the next speaker.